I'm Josephine Gittler, and I'm a professor of law at the University of Iowa College of Law. I'm going to be talking to you today about the legal framework for surrogate decision-making. All adults are legally presumed to have the capacity, the cognitive capacity, to make decisions on their own behalf. However, the law recognizes that this presumption may not be valid for some adults. For example, older adults with Alzheimer's disease and other dementias may have had at one time the capacity for decision-making, but because of the disease of Alzheimer's or other dementias, they no longer do. Therefore, there are severally legally recognized vehicles for surrogate decision-making for an adult who lacks decision-making capacity that have been developed. These vehicles include a power of attorney for health care, a durable financial power of attorney, representative payee arrangements, guardianships, and conservatorships. I'm going to now talk to you briefly about each of these recognized legal vehicles for surrogate decision-making. First of all, there are provisions in the Iowa Code for surrogate decision-making involving health care and end-of-life decision-making. The Iowa Code, Chapter 144A, is called the Life Sustaining Procedures Act, and it provides for what the code calls a declaration, what most of you would think of as a living will. Chapter 144B of the Iowa Code provides for a power of attorney for health care. Here you see the provisions for a living will, a declaration, and please note that the statutory language has several terms which are defined in the statute. Here is the statutory authorization for execution of a declaration, which I refer to as a living will. Please note that there are several terms: declaration, life-sustaining procedures, and terminal, which are specifically defined in the statute. In this case, as in all cases with statutes, you should always be cognizant of the need to look up the definitions of terms that are used in a statutory provision. Here you see the statutory authorization for a health care power of attorney. A durable power of attorney, as the statute indicates, means a document authorizing an attorney-in-fact, an agent, to make health care decisions for the principal if the principal is unable in the judgment of the attending physician to make health care decisions. Health care and health care decisions are specifically defined in the statute. So, in sum, one vehicle for substitute decision-making or surrogate decision-making with respect to healthcare decisions is a declaration or living will and a durable power of attorney for healthcare. Another vehicle for substitute or surrogate decision-making is a durable financial power of attorney, familiarly known as a POA. A power of attorney is a legal document in which one party, the principal, gives authority to another party, the agent, to make decisions for him or her with respect to management of their financial affairs. The Iowa Code specifically authorizes durable power, financial power of attorneys. And here you see the statutory, the relevant statutory citation. That is the Act, the Iowa Power of Attorney Act, establishes a comprehensive legal framework for the creation and use of POAs. It furnishes guidance to and protection for principals, agents, banks, and other financial institutions that may be in the position of accepting a POA. A major purpose of the Act is to reduce the serious problem of POA abuse, that is, misuse of authority by an agent. Another form of substitute decision making is known as representative payee arrangements. A representative payee as an individual, agency, organization, or institution that is appointed by a governmental entity to receive funds on behalf of a beneficiary. Here are some of the federal agencies that use representative payees: Social Security Administration, the Veterans Affairs Administration, the Railway Retirement Board, the Office of Personnel Management, and the Department of Defense. The representative payee receives funds from these types of agencies on behalf of an individual that lacks the capacity to manage his or her financial affairs. That brings us to guardianships and conservatorships. All of the vehicles that I have discussed so far for substitute or surrogate decision making in the event an adult lacks the capacity to make decisions on his or her own behalf do not involve the court. And they constitute vehicles that can be used to prepare for potential incapacity, i.e., it is good practice for an individual, particularly an aging individual, to execute a healthcare power of attorney and a durable financial power of attorney in case they become incapacitated. If they do not execute a valid healthcare power of attorney or a durable financial power of attorney, then there is no one that can legally make decisions for them unless a guardian or a conservator is appointed. The Iowa Code does specifically provide for the appointment by the Court of Guardians and Conservators. A guardian is a person appointed by the court to have custody of the person of an adult and who makes decisions on his or her behalf about matters such as living arrangements and health care. A conservator is a person appointed by the court to have custody and control of an adult and to make decisions about his or her financial matters. The Iowa Code uses the term ward to refer to a person for whom a guardianship or conservatorship has been established. There are 22,000 approximately total persons under guardianship and conservatorship in Iowa. A significant number of adults under guardianship and conservatorship are older adults who lack decision-making capacity due to conditions such as Alzheimer's disease or other types of dementia. There are statutory criteria for an adult guardianship. The person must be one whose, quote, decision-making capacity is so impaired that the person is unable to care for the person's personal safety or attend to or provide for necessities for the person, such as food, shelter, clothing, or medical care, without which physical injury or illness might occur, end quote. The statutory criteria for conservatorship is a person must be one whose, quote, decision-making capacity is so impaired that the person is unable to make, communicate, or carry out important decisions concerning the person's financial affairs, end quote. Once a guardianship or conservatorship is established, the court has the responsibility for monitoring the guardianship and the conservatorship to ensure that a person under conservatorship is receiving proper care and is protected from abuse and neglect. And the court has the responsibility to monitor a conservatorship to make sure that a person under conservatorship is protected from financial exploitation. The main way in which the court monitors is through a requirement that the guardian must prepare and submit an initial report and thereafter annual reports dealing with the status of the person under guardianship. And the main way the court monitors conservatorships is through a requirement that the conservator must prepare and submit an initial report, an inventory, and an annual report. There have been many problems, not only with the Iowa guardianship and conservatorship system, but with state guardianship and conservatorship systems around the country. And in the last 10 years, a number of states have established task force commissions, etc., to improve, to reform their guardianship and conservatorship systems. In 2015, the Iowa Supreme Court issued an order establishing a guardianship and conservatorship reform task force and making appointments to the task force. The Supreme Court order said the following: its purpose was to, quote, review Iowa's guardianship and conservatorship laws and procedures in order to ensure the system is efficient and responsive to the needs of Iowans. More specifically, the Iowa Supreme Court said that the task force was to, quote, develop recommendations for effective and efficient guardianship and conservatorship laws, practices, and procedures, and develop recommendations to foster continuous improvement to the guardianship and conservatorship system to ensure it is responsive to future generations of Iowans. The task force is organized as following. There is a steering committee, which is responsible for overseeing the work of the task force, and there are several work groups that are responsible for developing recommendations for the task force in various subject matter areas. In addition, there's a resource committee made up of professionals with expertise in professional evaluations of individuals with respect to their decision-making capacity. There are over 70 individuals serving as members of the steering committee, the work groups, and the resource committee on clinical evaluations. This membership is representative of multiple stakeholders in the Iowa guardianship and conservatorship system: the bench, judges and other judicial branch personnel, the bar, state agencies, guardians and conservators, banks and bonding companies, disability, aging, mental health, brain injury organizations, and advocates. Thank you very much for listening to my presentation.
Hello, my name is Kitty Buckwalter, and I'm a professor emerita from the College of Nursing at the University of Iowa, as well as co-director of the National Health Law and Policy Resources Center. I'm going to be speaking about client capacity assessment and decisional capacity assessment in particular. But before I get into that content, I want to review some things that may affect one's ability to obtain an accurate assessment of the older adult, which includes some of the cognitive and functional limitations associated with aging, as well as the communication process itself. Because these are really background factors, I'll go through the first set of slides rather quickly, but I want us all to be on the same page so we understand how to conduct the best possible capacity assessment that gives the older adult the best chance of getting an accurate assessment. You may be wondering how these things relate to Professor Gittler's presentation. Well, if a person is determined to lack decisional capacity for a particular decision, a determination for surrogacy is necessary. So they may then be appointed a legal guardian or a durable power of attorney, a spouse, an adult child, and that's the relationship between the two aspects of our presentations. So let's begin then with looking at the disclosure statement, and I have nothing to disclose. The objectives for today are to understand factors that can influence a decisional capacity assessment, and then also list components of a capacity assessment conducted by a healthcare professional. Talking a little bit then about the effects of aging, we know that as people age, some, but not all, have functional and cognitive limitations. These often result from health problems or disabilities. And these functional and cognitive limitations may influence the way a person responds to questions and affect their assessment of decisional capacity. Among the two most important are sensory impairments, and as you can see on this slide, both vision and, with the next slide, hearing are commonly affected in late life and will affect one's ability to communicate and respond to questions accurately. Many times if a person has a sensory impairment, and all five senses do diminish as part of the aging process, they may appear to be more incapacitated than they actually are. I will never forget an individual who was referred to me in my practice out of a community mental health center who had been deemed to be incapacitated, whereas in fact actually had such a huge buildup of earwax that she could not properly hear the questions, but like many older adults, was afraid to admit that she wasn't hearing things, so responded in inappropriate ways that made her seem cognitively impaired, when indeed with a cerumen spoon and digging out that earwax, she was perfectly intact. So we have to consider these types of impairments. Also, speech and language impairments may affect older adults. The word aphasia literally means without speech, and aphasia may develop due to strokes or head trauma or dementias like Alzheimer's disease. And they affect the ability to express oneself through speech and to understand the spoken word. They can range from mild to very severe, and dysarthria is really a medical term that simply means the person has difficulty speaking because they aren't able to form or articulate the words. They may have slurred speech or be hard to understand, and you can of course see how this could affect a clinical interview for decisional capacity. When we're talking about cognitive functioning, which is a key element of any decisional capacity assessment, it's really on a continuum from normal age-related changes to severe dementias. And I say dementias and not just Alzheimer's disease because Alzheimer's disease, although it's the leading cause of dementia, is only but one of many different types. Kind of in between on this continuum is mild cognitive impairment, a sort of intermediate stage of cognitive decline between that of normal aging and the dementias, which may or may not progress to become a full-blown dementia. So there are many elements to cognitive functioning which may be part of a capacity assessment. A commonly held misconception is that aging results in an inevitable loss of cognitive abilities and that nothing can be done to halt this decline. However, we know that certain areas of thinking show normal declines as we age, whereas others remain unchanged, and some, like reasoning or problem solving, may actually improve. That's the wisdom effect as we age. Next, I'd like to talk a little bit about communication with older adults, because clearly the way we go about assessing, as we'll discuss in Part 3, is a directed clinical interview or in response to standardized tools for assessment of capacity. The person with the inability to communicate normally can affect the assessment by healthcare professionals or attorneys in terms of their understanding of the assessment of decisional capacity. And in this section, I want to briefly review some of the factors that we should all consider when assessing for decisional capacity. As you can see from this slide, the components of communication are complex. We always think of words used or messages, and of course they're an important part of communication, but there's a lot more to it than just that. Communication is a dynamic process that involves both verbal and nonverbal messages and internal and external feedback that occurs in a specific context or situation, so that when we're conducting a decisional capacity assessment or capacity assessment in any domain, we must attend to elements of the context or environment that the person is in. And again, both verbal and nonverbal messages are very important. It's not so much the words that we actually say, but it's how we say those words, our tone, the messages that we communicate with our hands, with our facial expression, and so forth. So the communication process is a multi-layered one that includes perception of what's said or asked, how that's evaluated by the person who's being questioned, let's say in an assessment of capacity examination, and the process of transmitting messages. And how a person behaves depends on their perception of what's being said or asked and their evaluation of the situation, not necessarily the actual events themselves. What was communicated to them? How did they perceive this? And many times, as we know, older adults are very anxious if they perceive themselves to be in a testing situation, or their evaluation of the situation. They may be uncomfortable. Maybe they have driven a long ways. Maybe they have arthritic pain. Maybe they're hungry or thirsty. All of these elements can affect the way a person responds in a capacity assessment situation. Our knowledge as healthcare professionals and values affect what we see and how the information is interpreted and understood by the person we're evaluating. It also plays into how we respond to their comments. Again, remember, this can be our verbal response as well as our nonverbal response. Just a look can often communicate something very telling. A critical part is to avoid ageist beliefs. As we'll see, many people think that just because you're over the age of 65 or 85, you're automatically impaired and unable to make decisions for yourself. As we'll learn when we talk about capacity, it's very common for people to have capacity in one domain and yet another, and not have capacity in another. And yet we tend to assume that if one aspect of a person's capacity is impaired, then it's a blanket thing where everything is impaired. We also must never assume that all persons have problems with their memory and processing and understanding information, particularly if they have something like aphasia and they may perfectly well understand what we're saying, but they just have difficulty responding to our questions. It's very important when conducting a capacity assessment to consider, first of all, the environment, and then adjust the environment to make it the best possible one for an older adult to respond. So think, what's going on in the background? Is it noisy? Is the public address system blaring out and calling people to lunch or to get their medications? Are there other distractions, such as someone wandering in the room who has dementia, a family member mistakenly opening the door while you're conducting an assessment, or the pet therapy dog wandering in and pooping in the room during the capacity assessment? We often have ambient noise that older adults don't do well with, televisions, radios, and things in the background that can distract them and keep them from responding optimally. We also very much need to consider their personal comfort. This can be both physical and psychological. As I mentioned earlier, often the process of assessment is anxiety-provoking for older adults. They don't want to fail. They're concerned what will happen to them if they flunk the assessment. So we need to be reassuring that way. We also need to think about what time of day is it. Have they gone to the bathroom? Have they had something to eat or drink recently? And we may overwhelm them in our desire to conduct the assessment in a certain amount of time, whereas they may benefit from shorter periods of questioning, pausing between, asking, is there anything you need? Are you comfortable? How's the temperature in the room? Is that chair too hard for you to sit on? Those kinds of questions can help to assure comfort. And you may recall the earlier slides about changes in sensory impairments such as vision and hearing. And so we want to make sure that the person we're assessing for capacity has all of their visual aids, they're clean, the lighting is adequate, that if they're reading something off of a piece of paper, the font is of adequate size for the older eye to see, sufficient time allowed not only to read materials but to respond to them using color contrasts and so forth. Also, it's important if there are changes in hearing that the person has their hearing aid, and importantly also that the batteries are fresh in that hearing aid. Some tones are not heard as well as others and need to be overly pronounced and in a lower pitch of voice. Looking directly at the person we're talking to, speaking slowly and distinctly, and again, minimizing background distractions. It's also incumbent upon healthcare professionals to adjust their approach. Slow down and listen. Allow adequate time to retrieve information and respond. Always identify yourself by name and call the person you are assessing by their preferred name, which should be determined well in advance of the capacity assessment. Don't rely on medical jargon. Do you need to micturate? Do you have to go to the toilet? These kinds of things are much easier for the person to respond to, even though we're comfortable with jargon and phrases. But try and determine how the person will respond or how they understand a particular medical condition or treatment, especially when we're seeing if they consent to, let's say, a surgical or medical intervention. Always adjust your approach. Find out if the person is understanding what you're asking them. Can they read any simple instructions you may prevent? Do they understand the instructions? We know, for example, that in dementias, multiple commands or requests are not well processed. And so we should ask simply one thing at a time, maybe re-ask it a bit later, before we go on and ask something else. So it's incumbent upon the healthcare professional to do whatever you can do, both environmentally and in terms of communication, to ensure that the client is able to respond successfully and optimally, so they aren't miscategorized as lacking capacity when in fact they do. So if we ask a question of an individual, sometimes it can help to provide them with cues in terms of things that we're looking for. It may be something as simple as saying, instead of saying an open-ended kind of vague question was, when was the last time you saw your doctor? You might say, have you seen your doctor since the new year? Now that gives the person a grounding and a sense of something to respond to. So again, pay particular attention to nonverbal communication. What the person is saying in terms of their words may actually not match the way they look. They could be anxious but afraid to admit it. They could be cold and uncomfortable during the assessment process. And so it's important for healthcare professionals to clarify how they are communicating nonverbally, as well as to probe and see if they understand how the person who's being assessed is communicating. And there's examples here on this slide. Also, we know that expressive abilities can be impaired, especially with neurological conditions like the dementias. And many times there's a loss of ability to actually name objects. So the person may say, oh, that thing with 4 legs, when they in fact mean a chair. So we have to help them to communicate by asking if that's indeed what they mean, and understanding that frustration comes with the inability to express what one wants to say. Now we'll get to the heart of this presentation, which is actually on the assessment process itself. Capacity describes a person's ability to make a decision. In a medical context, capacity refers to the ability to use information about an illness or a proposed treatment to make a choice that is congruent with one's own values and preferences. In particular, decisional capacity is the ability to consent or to refuse care. It is closely related to competence, but competence can only be determined in a court of law. The literature suggests that somewhere around 40% of older adults and medical inpatients may lack decisional capacity. This is a very large percentage, so it's something every time that we ask for informed consent that absolutely must be assessed. Sometimes because we're busy or we don't perceive the importance of capacity assessment, it may only be conducted when the person disagrees with our prescribed course of treatment. If we say you need surgery to remove that lump on your left arm, and the person says you're not touching me with a scalpel, then that may prompt a capacity assessment so that we can go ahead and do what we think is right professionally. But really, in any situation, no matter whether the person agrees or disagrees, anytime you're obtaining informed consent, a decisional capacity assessment should be offered. Now, there are, as we've covered, a number of things that may be risk factors for impaired decisional capacity. We certainly talked about age, but again, not everyone, because they're of a certain age, is incapacitated. Also, cognitive impairment is closely associated with lack of decisional capacity. Many times we assume because the person has a diagnosis of a psychiatric illness that they have no decisional capacity, and that is in fact not the case. It's true that certain types of psychiatric illnesses, say schizophrenia, may more commonly involve decisional capacity than, say, a depression, but not always. Certainly, illnesses with lack of insight as a component are thought to be strong predictors of lack of decision-making ability. So, in regard to the clinical perspective, because there's also a legal perspective for capacity assessment, one of the most important things to do is to have a sound diagnosis. If you're unable to make that diagnosis yourself, then you must refer out and get an accurate diagnosis. Also to assess for cognition and for function, and then bring a variety of these factors together listed on this slide and call clinical analysis. How then does one assess for decisional capacity? There are 4 key elements involved in this decision. The ability to communicate a choice, the ability to understand relevant information, the ability to appreciate a situation and its consequences, and the ability to reason rationally. I should also say that when assessing for cognition, it is critically important that one determine that the person is not experiencing a delirium or an acute confusional state. This could be the result of an untreated urinary tract or upper respiratory tract infection, an adverse medication response, or just lack of hydration. So one of the first things we may do is to make sure that the person is not, in fact, delirious before they undergo their assessment. I'd like to just provide some examples of questions that we may ask to determine decisional capacity according to the 4 elements that I just listed. So the first one is to communicate, ability to communicate a choice. Can the patient or resident indicate a preferred treatment option? We may ask them, first of all, to indicate a treatment choice. Have you decided whether to follow your doctor's recommendations for treatment? And that could be surgery or a particular medication or whatever. Can you tell me what your decision is? Remember, their preferences are an important part of decision making. If they're unable to respond to this in terms of what your decision is, then say, can you tell me what is making it hard for you to decide? The second element is understanding relevant information. So we want to determine, does the individual grasp the fundamental meaning of information that's been communicated by their healthcare professional, usually a physician in this case. We want to encourage the patient to paraphrase disclosed information regarding medical conditions and treatment. So tell me in your own words what you understand about your health problem, about the recommended treatment, any alternative treatments, their risks and benefits, and what you perceive to be the risks or benefits if you select no treatment options. That's the kind of thing you would do in a capacity assessment. The third element is to determine if the person can appreciate the situation and its consequences. Can they, in fact, acknowledge that they have a medical condition and the likely consequences of the treatment options? You might ask the patient or resident to describe their views of their medical condition, and sometimes it may be something as, well, I'm just tired because I haven't been getting enough sleep since I got my new roommate, when in fact there's something else really going on, but they will offer an alternative explanation that suggests they don't truly appreciate their healthcare situation and the consequences of that situation. So what do they understand to be the proposed treatment, and what are the likely outcomes? Will they in fact have a limb amputated? And what does that suggest about their mobility and that sort of thing? So you might ask questions such as, what do you believe is wrong with your health now? Do you believe you need some kind of treatment? And many older adults will in fact be in denial or simply be unaware of their situation. So it's important to determine this. What is the treatment likely to do for you? What makes you believe that it will have this effect? And what do you believe will happen if you are not treated? Because they may tell you they prefer not to have surgery or not to start on a particular medication and so forth. And why do you think your doctor has recommended this particular treatment for you? The final element to determine in a decisional capacity assessment is the ability of the individual to reason about their treatment options. Can they engage in a rational, very important word here for people, especially those with cognitive incapacity, process of manipulating relevant information? You might ask them to compare treatment options and consequences and to offer reasons for selection of an option. For example, how did you decide to accept or reject the recommended treatment? What makes whatever their chosen option is better than, say, an alternative option. So this is conducted during what's called a directed clinical interview. And the point of this interview is to determine if the individual understands their medical condition and their options for care. Now, it's important to know that lack of any ability, any one ability, and remember there are the 4 domains here, does not mean that the patient or resident lacks overall ability. It can be element specific. And many times, the lack of ability may be related to things like limited education. Sometimes we see people who lived during the Depression and didn't go to school past the 6th grade. They don't really understand the questions. Cultural background may influence the response, or lack of experience and associated anxiety in a particular medical setting may also influence that. So I want you to remember, and this is probably, I would say, the key point of what I'm presenting today, is that decisional capacity is decision specific. That means that a person may be competent to choose, for example, someone to be their durable power of attorney, or decide that where they want to live, but not to make a more complex or complicated decision about the best kind of surgery for themselves. So again, it's not a one-size-fits-all. They may retain capacity over some aspects of their health and person, but be unable to make competent decisions in other aspects. And again, as I mentioned at the beginning of my talk, if the person is deemed to lack decisional capacity, then they may be determined to need a surrogate, such as a legal guardian for healthcare decision-making or a durable power of attorney. Remember, too, that even if the person is determined to lack decisional capacity, you still want to discuss their medical decisions with them. And if they refuse a procedure, then continue the discussion so everyone understands what is going to happen, and try and come to some consensus or agreement. There are a number of ways, in addition to the directed clinical interview that I talked about, to determine more formally assessment. 2 of the tools that are commonly used by healthcare professionals, most likely psychiatrists or neurologists or primary care physicians, who most often conduct these kinds of assessments. 2 of the best known and often used are the Aid to Capacity Evaluation, or the ACE tool, and the MacArthur Competence Assessment tool. If you, as a healthcare professional, are uncomfortable conducting these kinds of capacity assessments, then it is critical that you refer to someone who is able to make these judgments, and that's what I want to continue talking about. Just to reinforce that capacity is variable. A person may have capacity in some domains or decision-making and not others, but it's not a one-size-fits-all, and that there are a variety of environmental, personal, disease-related factors that can affect their ability to respond well to a capacity assessment. So it's very important that we assess for basic cognitive functioning in terms of decisional capacity. One instrument that you're probably familiar with is the mini mental state exam. This is a screening instrument and not a full-blown tool for cognitive assessment, but it's a useful start, and it's better than nothing if you're requesting an assessment or making a recommendation about somebody. There are a variety of other tools that can be used for assessment of cognition. Many of them are included in the reference here, the appendix to the American Bar Association, American Psychological Association Handbook for Lawyers. Others, you can simply Google. The National Institute of Aging webpage has capacity assessment recommendations. Brief cognitive screening tools are also available, and most of those are reliable and valid. The brief cognitive assessment tool, the cognitive capacity screening, the Montreal cognitive assessment tool. The Alzheimer's Association, for example, has a toolkit that's available for assessing capacity. And again, you could simply go online and order that toolkit as a way to know that you're using valid and reliable, standardized screening tools. I personally believe that the directed clinical interview is the most important way to determine capacity, but may well be augmented by some of these standardized tools like the MacArthur or the ACE. So who is an appropriate clinician to be able to conduct a capacity assessment? Well, there are a variety of candidates for this. As I said, many times it's a geriatric assessment team, but that's often at a tertiary or specialized healthcare center. Commonly, people with a mental health background or neurological background, or primary care physicians do these kind of assessments. In rural areas, and Iowa is comprised of many, many rural settings, we often don't have the luxury of having our capacity assessments conducted by the neuropsychologist next door. And it may be determined that the person doesn't tolerate an ambulance ride all the way to a tertiary care center where these practitioners are available. So I believe, and perhaps because of my nursing background, that geriatric nurse practitioners, social workers with advanced preparation can be trained and tested in terms of their capacity to conduct valid and reliable assessments. And certainly this is better than recommending that somebody get a durable power of attorney with absolutely no background information at all. And just as I said before, just because of their age or diagnosis, they may lose control of their person or property. So if you're asking for a referral from one of these advanced healthcare professionals, these are the elements on this slide and the next slide of what should be included in that referral letter. Why are you asking for this? What type of capacity? Because there are many types of capacity. One that you may well know about is financial capacity. This is the growing type of abuse among older adults, but the assessment for financial capacity is very, very different than the assessment for decisional capacity that we've been talking about. Provide as detailed a list of what medical, functional, behavioral information you have. The person's background and living situation, social environmental factors that may come into play, their values and preferences if they've been explained to you, because, as I said earlier, that's an important part of decisional capacity making. And whether there should be some sort of personal or phone contact before a written report is issued. What you can expect to receive, or if you are in fact one of the healthcare professionals who's doing one of these capacity assessments, these are the elements that should be addressed in your evaluation report. And I'm not going to read them to you, but you can see this is quite comprehensive and includes both clinical impressions, background material, historical information, your observations of the person's behavior as well as their responses, as well as any standardized test results that you may have administered. How can this information be used? Well, it may be used to determine their capacity in particular domains. Clarification of what strengths remain. Like I said before, the person may be able to determine where they want to live or who they want to represent themselves, but not whether they should have a particular surgery. It, again, will indicate if there's lack of decisional capacity, that there may be the need for surrogacy and that protective action is needed for the individual's benefit. Just in closing, I'd like to say it is critically important that documentation, both of formal standardized assessment scores as well as clinical impressions, and the basis for making a determination be documented and available to the court, who, after all, do make the final determination of legal capacity. But they are well assisted, not often enough, but should be, by healthcare professionals who examines the person's capacity. So in closing, I'd also like to be sure to acknowledge individuals who helped with the compilation of this presentation. Professor Gittler was extremely helpful, not only in content but in slide preparation, as well as Dr. Marianne Smith from the College of Nursing and the Iowa Geriatric Education Center in both regards as well. So thank you to Professor Gittler and Dr. Smith for their assistance with this presentation.